All right, welcome to the deep dive. Today we're cutting through the noise to unravel a complex but really crucial topic in equine health, urinary incontinence in horses. Our mission here is to take a deep dive into the latest on diagnosing and managing this challenging condition. We want to pull out the most important insights so you can really understand what's going on.
Yeah, and it's a condition that might seem simple, just involuntary urine leakage. But the reasons behind it, how you figure it out, and what you do about it are anything but simple.
Right.
So we're going to explore why it happens, what it actually looks like in a horse, how veterinarians kind of play detective to pinpoint the problem, and maybe most crucially what the long-term outlook is, because owner commitment here is, well, it's absolutely vital.
Okay, so let's unpack this. At its core, what are we really talking about? What defines this condition for a horse owner?
Simply put, equine urinary incontinence is when a horse involuntarily leaks urine. It could be constantly or just off and on, and it's completely unrelated to when they'd normally choose to urinate.
Okay, and how is that different from, healthy urination? 'Cause it sounds like there's a lot more to it than just letting go.
Exactly. Yeah, think of a healthy horse's bladder like a finely tuned balloon, maybe, with a clever little valve at the bottom.
Okay.
So when the bladder fills, the balloon part relaxes to hold the urine, and that valve, the sphincter, it cinches tightly shut.
Right.
Then, when it's time to urinate, the brain sends a signal. The bladder squeezes, the valve opens precisely at the same time, and you get a strong, controlled stream.
Makes sense.
Incontinence happens when that delicate coordination breaks down. The pressure inside the bladder just overwhelms the resistance of that valve.
That's a great analogy. So when that system goes wrong, what are the main ways it shows up? Are we talking different kinds of leaks depending on why it's happening?
We are, yeah. The core insight, I think, is that incontinence usually falls into two broad categories. It's either not nerve-related, we call that non-neurogenic, or it is nerve-related, which we term neurogenic. And within that neurogenic category, we often see two distinct patterns.
All right. Tell me about those.
Okay, so imagine the control wires from the brain down to the bladder. If there's damage to the main junction box, low down in the spinal cord, the sacral area, or the direct wires to the bladder and sphincter, we call that a lower motor neuron, or LMN, bladder.
LMN.
Right. With LMN, the bladder muscle itself becomes floppy, kind of weak, atonic, and the exit valve can't stay fully closed. This usually means the bladder gets really full because it can't empty properly, and then it just overflows.
Wow, overflow incontinence.
Exactly. So when a vet examines a horse like this, the bladder feels large, soft, and it's often easy to manually empty. You might also see other signs that those lower nerves are affected, like a flaccid tail or maybe issues with fecal control.
So the system is just too relaxed, basically, to hold it in properly. What about the other type?
So the other type is an upper motor neuron, or UMN, bladder. This happens when the problem is higher up in the spinal cord above the sacrum, or even in the brainstem.
Higher up, okay.
Here, the bladder often becomes sort of overactive, but the critical issue is that the exit valve, the urethral sphincter, becomes too tight, and it's uncoordinated with the bladder muscle.
Too tight. So the opposite problem.
In a way, yes. The bladder might feel firmly distended, and it's usually difficult for a vet to manually express urine. Horses with this type might leak in short, intermittent bursts. Sometimes it gets worse with things that increase abdominal pressure, like, coughing.
Interesting.
And you'll often see other neurological signs, too, things affecting the whole body, like a wobbly gait, ataxia, or general weakness, paresis.
Okay, here's where it gets really interesting and probably a bit tricky for vets. You mentioned that by the time this becomes a noticeable problem, the original cause may be long gone, right? Months or years.
That's often the case, yes.
And surprisingly, you said even a UMN bladder, the tight valve kind, can eventually start to look like an LMN bladder. How does that work?
Well, it's because the bladder muscle just gets stretched out and tired over time. It's constantly trying to push against that tight, resistant sphincter. Eventually, it just kind of gives up, loses its tone. Chronic detrusor dysfunction.
Wow. So what does this all mean for owners when they finally bring the horse in?
It really underscores why most affected horses we see present with chronic sort of end-stage bladder dysfunction. It's often reached a point where the bladder is overstretched, weak, leading to that persistent overflow incontinence, and it's often accompanied by secondary issues like bladder inflammation, cystitis, and that buildup of sabulous sediment.
What is that exactly?
Yes, sabulous sediment. It's like a chalky, gritty sludge, mainly calcium carbonate crystals, that accumulates in the bladder because it's not emptying properly.
Right. Okay, this brings up a critical question then. Why do horses present so late? It sounds like those early signs might be really subtle, or maybe owners just don't realize their significance.
I think that's exactly it. The early signs can be easily missed or maybe attributed to something else. It really highlights a crucial need for, increased awareness among owners. Because by the time the horse is showing obvious signs like constant dribbling or scalding, irreversible damage to the bladder muscle may have already occurred.
And that shifts the whole focus, doesn't it?
It does. It shifts the focus from aiming for a complete cure, which might not be possible anymore, to managing the complications and trying to maintain the best possible quality of life for the horse.
So, if we're often dealing with this late-stage problem, let's go back to the beginning. What are those initial triggers? What are the root causes that start this whole process?
Oh, the causes are incredibly diverse, really varied. They can range from issues a horse is born with congenital anomalies to problems acquired later in life that aren't nerve-related, and then, of course, various neurological disorders.
Okay, let's break that down. Start with the congenital issues, things a horse might be born with.
Sure. The most commonly reported one is something called ectopic ureters.
Ectopic ureters.
Yeah. Normally, the ureters, the tubes carrying urine from the kidneys, open directly into the bladder. With ectopic ureters, one or both tubes open abnormally. They might empty into the urethra, or in fillies, even the uterus or vagina.
Ah, so bypassing the bladder's normal storage function.
Exactly. So this usually means the incontinence is present right from birth. And interestingly, it seems to be more common in fillies. Another one, mostly in foals, is a patent urachus. That's where the tube that connects the bladder to the umbilicus before birth doesn't close properly, so urine dribbles from the belly button area.
Right, I've heard of that. Can be mistaken for bladder incontinence.
It can, yeah. Needs to be differentiated.
Okay, so some horses are just born with a plumbing issue, essentially. What about problems they acquire later but not related to nerve damage? The non-neurogenic ones.
Right, these are your acquired non-neurogenic causes. A big one is urolithiasis.
Bladder stones.
Yep, bladder stones. In horses, they're often calcium carbonate stones, and they tend to be more common in older geldings. These stones can irritate the bladder lining, cause pain during urination stringyria, and sometimes partially block the flow, leading to overflow or urge incontinence.
Okay, stones. What else?
Then there's cystitis, which is just bladder inflammation or infection. Now, while inflammation can cause urge incontinence, that feeling of needing to go right now, it's really crucial to understand this. Primary bacterial bladder infections are actually quite rare in horses.
Oh, really? I would have thought infections would be common.
They are common as a consequence, but usually not the primary cause. Cystitis typically develops secondarily because the bladder isn't emptying fully. That stagnant urine and the sabulous sediment we talked about create a perfect environment for bacteria to grow.
Ah, okay. So the infection follows the poor emptying.
Precisely. Trauma can also be a factor, especially in mares. Things like breeding accidents, difficult births, or even just repeated foaling can injure the external urethral sphincter muscle. We've also seen cases from veterinary procedures, iatrogenic trauma.
Sure.
Less common causes include tumors in the lower urinary tract, and very rarely something called estrogen-responsive incontinence in mares. That's linked to low estrogen levels, weakening the urethral sphincter tone. But the good news is it often responds well to estrogen therapy.
That makes sense. So stones, secondary infections, trauma, lots of potential non-nerve issues. But nerve damage, the neurogenic causes, that's a big category too, right? What neurological problems can lead to this?
Absolutely. Acquired neurogenic causes are really significant. For that LMN type of bladder paralysis we discussed, the floppy, weak bladder, common culprits include certain viral infections. Equine herpes virus type 1, EHV1, encephalomyelopathy is a big one.
EHV1, right?
Also, inflammatory conditions affecting the nerve roots near the tail, like cauda equina neuritis, even exposure to certain toxins like sorghum grass. And equine protozoal myeloencephalitis, EPM, that's another well-known neurological disease that can cause LMN signs, including bladder issues.
Right.
Plus, physical trauma to the sacral vertebrae or tumors affecting those nerves. Even, unfortunately, some veterinary interventions like epidural alcohol administration have been implicated.
Wow. And what about the the tight sphincter bladder?
Bladder dysfunction is generally less common, but it can also be associated with EHV1 or EPM or other spinal cord lesions higher up, cranial to the sacral segments, things like parasitic migration, trauma, or even conditions like Wobbler syndrome, cervical stenotic myelopathy.
Okay.
And then there's this fascinating and often really frustrating condition called idiopathic bladder paralysis syndrome.
Idiopathic meaning we don't really know the cause.
Exactly. It primarily affects geldings. They present with incontinence and often significant sabulous urolithiasis, but frequently without other obvious neurological signs.
Huh. So what's the theory there?
The suspicion, or the leading theory, is a link to chronic pain, particularly in the lumbosacral region or the hind limbs. The idea is that this pain makes it difficult or uncomfortable for the horse to get into the proper posture to urinate completely. Over time, this leads to incomplete emptying, sediment buildup, and eventually bladder paralysis.
That's fascinating, the posture itself being a factor.
It seems plausible, yes.
So when we look at the bigger picture here, it sounds like the causes are incredibly diverse, but they often converge on a similar downstream problem, that incomplete bladder emptying.
That's a perfect way to put it, that incomplete emptying is really a central theme.
And this then creates a whole host of predisposing factors and potentially a vicious cycle, right?
Absolutely. Several factors can make a horse more susceptible. Gender, as we touched on. That idiopathic bladder dysfunction is more common in geldings. Mares, on the other hand, are perhaps more prone to lower UTIs because they have a shorter, wider urethra, and they're also more susceptible to trauma-induced incontinence from foaling.
And geldings get more stones.
Geldings are definitely overrepresented in urolithiasis cases, partly because their urethra is longer and less distensible, making it harder to pass small concretions.
Okay. What about age?
Age definitely plays a role. Congenital issues obviously are present from birth. Foals can be susceptible to certain UTIs. And then urolithiasis and chronic UTIs tend to be more common in older animals.
And diet. You mentioned alfalfa earlier.
Yes, diet can contribute. High calcium intake, especially from forages like alfalfa or clover, can definitely contribute to the formation of those calcium carbonate stones.
Okay. Any underlying diseases?
Sure. Things like diabetes mellitus, although rare in horses, can affect nerve function. A compromised immune system could make them more prone to infection. Chronic vaginitis in mares might predispose them to ascending infections.
And that musculoskeletal pain link seems really important too.
It really is. Musculoskeletal pain, especially chronic pain in the lower back, sacral region, or hind limbs, is often overlooked. If a horse can't comfortably stretch out or posture correctly to urinate, they may consistently fail to empty their bladder completely. And that, as we've said, sets them up for sabulous urolithiasis and progressive bladder paralysis.
So what's the really critical takeaway here? It's usually not just one thing, is it?
Rarely. For most horses with significant incontinence, it's not a single event. It's often become a complex, interconnected, and even self-perpetuating cycle. The consequences of the initial problem, like the incomplete emptying, actually exacerbate the primary bladder dysfunction. This leads to secondary issues like the sediment and the cystitis, which then feed back and make the original problem even worse.
Understanding those interdependencies seems absolutely critical then for both owners and vets.
It really is.
Okay, given all that complexity, how would an owner even notice this starting? What are the key red flags they really need to be looking out for?
Well, the most obvious primary sign is the dribbling of urine. It might be constant or it might be intermittent. You'll see it from the vulva in mares or the penis in stallions and geldings, and it happens both when the horse is resting and during activity. Sometimes, as we mentioned, it might seem worse when they cough or strain.
Okay, visible dribbling. What else?
You'll often notice a distinct urine odor around the horse more than usual, and in more chronic cases, you'll definitely see staining and scalding of the skin. Around the perineum in mares, down the hind legs in geldings. That constant urine exposure is very irritating.
Painful too, I imagine.
Oh, absolutely. Urine scald is very uncomfortable.
Might they still urinate normally sometimes?
Some horses may still posture and urinate voluntarily, yes, but often the stream will be noticeably weak or interrupted.
Okay, so beyond just the leaking, are there other clues? Those associated signs you mentioned sound crucial for figuring out the why.
They absolutely are. They provide important hints about the underlying cause. We look for general signs first. Does the horse have a fever? That might suggest an infection, like bacterial cystitis, or even something systemic, like EHV1 myelopathy. Are they depressed? Lethargic.
Okay. And specific urinary signs.
Yes, urinary tract specific signs. Things like trying to urinate very frequently, maybe just small amounts, that's polyuria, or showing signs of difficulty or pain during urination, dysuria or stranguria. You might see outright blood in the urine, hematuria, especially after exercise. And if there are bladder stones causing blockage or severe irritation, you might even see signs of colic or lower abdominal pain.
And if it is nerve damage causing it.
Then you'll often see other neurological signs. This is really key for diagnosis. Things like ataxia, that wobbly, uncoordinated gait, or paresis, which is muscle weakness, maybe dysmetria, where their movements are clumsy, overreaching, or underreaching.
Affecting the limbs.
Yes, often affecting both the front and hind limbs, or sometimes predominantly the hind limbs. You might also see that flaccid tail paralysis we talked about, or fecal retention because the nerves controlling that are nearby. Loss of anal sphincter tone, maybe diminished sensation around the perineal area. Sometimes muscle wasting in the hind limbs, or penile paralysis in male horses.
Wow, quite a range of neurological signs. Are there any specific differences we should mention based on gender or age?
Yeah, a few things to keep in mind. For mares, owners sometimes confuse the frequent urination posture seen during estrus, when they're in heat, with true incontinence. Also, urine cooling in the vagina is a distinct condition but might be misinterpreted. And, as we said, breeding injuries or difficult falling are specific potential causes in mares.
Okay. And for foals and geldings?
For foals, that patent urachus urine dribbling from the navel needs to be ruled out, as it can look like lower urinary tract incontinence. And for geldings, remember that idiopathic bladder paralysis syndrome, often complicated by the sabulous stones, is predominantly seen in them.
This really highlights how crucial those associated signs are for providing initial clues. But it sounds like even with all those clues, clinical signs alone can be really misleading sometimes.
That's absolutely spot on. While they guide the whole investigation, the outward signs alone are rarely, if ever, enough for a definitive diagnosis. Similar symptoms, like dribbling, can stem from vastly different underlying problems. Stones, nerve damage, trauma, and each requires a very distinct management strategy.
So you can't just guess based on the leak.
Definitely not. A thorough, comprehensive diagnostic workup is always necessary to get to the bottom of it.
So it really does sound like a medical mystery sometimes. How do veterinarians become these detectives and actually pinpoint the exact cause, especially given that subtle onset and all these overlapping possibilities?
It truly does feel like detective work sometimes. It always begins with taking incredibly detailed history. This is paramount, especially because, as we've said, the original trigger might have been months or even years in the past.
Right. What kind of things do you ask about?
Everything. The horse's age and gender, which already helps narrow things down, reproductive status and history, especially for mares. What's their environment like? Their diet, any access to potentially toxic plants? What about calcium intake, like lots of alfalfa? Any history of previous veterinary procedures? Any known trauma? Any potential exposure to infectious diseases like EHV1? Any signs of musculoskeletal pain or stiffness? Even their deworming history can sometimes be relevant.
Okay, a thorough history. After the conversation, then what?
Then comes a comprehensive physical and neurological examination, very hands-on. During the general physical, we'll try to observe their urination patterns if possible, the posture, the stream strength, the urine color, the volume. We check carefully for fever, any evidence of that urine scalding or unusual odors. We'll gently palpate the lumbosacral area, feeling for any pain or sensitivity.
And the neurological exam, you said that's essential.
Absolutely essential for every incontinent horse. This is where we try to differentiate between those UMN and LMN patterns. Is the horse showing widespread signs like ataxia and paresis, and does the bladder feel firm, turgid, difficult to express? That points towards UMN. Or are the signs more localized to the rear end, flaccid tail, poor anal tone, fecal retention, and is the bladder large, sloppy, and easily expressed? That suggests LMN.
Got it. So history, physical neuro exam. What about lab tests? What can blood and urine tell you?
Clinical laboratory tests are definitely crucial. Basic blood work, a CBC and chemistry panel, can show signs of inflammation or infection like an elevated white blood cell count or fibrinogen. But the urinalysis is really vital. We examine the urine sediment under a microscope. We look for crystals. Calcium carbonate crystals are normal in horse urine, but seeing excessive amounts is significant if we suspect sabulous urolithiasis. We look for red blood cells, hematuria, white blood cells, pyuria indicating infection or inflammation.
Bacteria.
Yes, a urine culture and sensitivity is key. We need to collect a sterile urine sample, ideally directly from the bladder using a catheter to avoid contamination. The culture identifies any specific bacteria growing, and the sensitivity tells us exactly which antibiotics will be effective against them.
And you stressed before, infection's usually secondary.
Exactly. It's worth repeating. Primary bacterial cystitis is rare. It's almost always secondary to urine retention and that sabulous sediment buildup. So finding bacteria tells us there's an infection to treat, but it doesn't usually tell us the original cause of the incontinence.
Right. Okay, beyond blood and urine, can you actually get a look inside the horse?
Imaging. Absolutely. Diagnostic imaging is often the next step and can be incredibly revealing. Transrectal ultrasonography is very commonly used and very valuable. The vet uses an ultrasound probe placed rectally to get images of the bladder and other pelvic structures. It's great for confirming sabulous cystitis. You can actually see the swirling sediment. It can identify bladder stones, uroliths, or bladder wall tumors or thickening. It might show congenital anomalies like ectopic ureters or dilation of the ureters or kidney pelvis, suggesting back pressure.
Ultrasound is powerful. What else?
Endoscopy, specifically cystoscopy, is another really powerful tool. Here, we pass a flexible or rigid endoscope, a small camera up the urethra and directly into the bladder. This gives us a direct, real-time, magnified view of the bladder lining, the mucosa.
What can you see with that?
We can see inflammation, hemorrhage, maybe strands of fibrin, that thick sabulous sediment coating the walls. We can directly identify bladder stones, masses, or structural abnormalities like those ectopic ureteral openings. Endoscopy can also be therapeutic. Sometimes small stones can be removed via the scope, or a laser fiber can be passed through it to break up larger stones, which is called laser lithotripsy.
Okay. Any other imaging techniques?
Sometimes, MRI is becoming more available for certain urinary tract conditions. Contrast studies where dye is injected can be very useful. A retrograde urethrocystogram involves injecting dye up the urethra to outline the urethra and bladder, good for finding tears or strictures. An excretory urogram involves injecting dye into the bloodstream, which is then filtered by the kidneys and outlines the ureters and bladder as the urine flows down. This is often used to confirm suspected ectopic ureters.
And for the really complex cases, you mentioned even more advanced diagnostics.
Yes, particularly at referral centers or universities, urodynamics can be performed. These are specialized tests that measure pressures within the bladder and urethra during filling and emptying. They assess how well the urinary sphincter and the bladder muscle, the detrusor, are actually functioning.
And that tells you.
It gives really valuable information about the type and severity of the dysfunction. And critically, it can provide important prognostic information. Horses that still have some ability to generate pressure within their bladder during these tests are generally more likely to respond positively to medical treatments.
This brings up a really crucial realization, and frankly, a bit of a sobering statistic you mentioned earlier. While vets can figure out the cause in maybe 80% of cases,
Approximately, yes.
only about 20% are actually successfully treated, meaning cured or significantly resolved. It's a huge gap. What does that tell us about the whole diagnostic process?
It tells us that, unfortunately, by the time many horses are presented to the vet, the condition has often been going on for a long time, and significant, often irreversible changes have occurred, especially to the bladder muscle itself. So the diagnostic process isn't just about finding the initial spark, the original cause. It's equally about assessing the degree of chronicity, the extent of the secondary damage, like the bladder wall thickening or loss of muscle function, and the presence of complications like severe sediment or infection.
Because that dictates the real possibilities for treatment.
Exactly. It directly impacts the realistic therapeutic options and, ultimately, the horse's long-term prognosis.
That really puts it in perspective. So the diagnosis is in, but the success rate for a cure is often low. What are the options then for managing this challenging condition, especially when a full recovery isn't on the table?
Yeah, it often becomes about management rather than cure. We use a multi-pronged approach, starting with medical management. If there's a secondary bacterial bladder infection, and remember they're almost always secondary, then appropriate antibiotic therapy is crucial. This should always be guided by that culture and sensitivity test to ensure we're using the right drug and hitting the right bacteria. The goal is to treat the current infection and help prevent it from ascending up towards the kidneys.
Okay, antibiotics for infection. What about medications to actually help the bladder function better?
Vets often try various pharmacological agents, but it's really important for owners to understand a key limitation here. Many of the dosages and protocols we use are extrapolated from human or small animal medicine. There's unfortunately limited equine-specific pharmacokinetic data studies on how horses absorb, distribute, and eliminate these drugs.
So it requires some careful judgment from the vet.
A considerable amount, yes. We might use drugs like bethanyl chloride. It's a parasympathomimetic, meaning it stimulates the parasympathetic nervous system, which normally triggers bladder contraction. The idea is to help the detrusor muscles squeeze more effectively.
Does it work?
It can be most beneficial if the bladder muscle still retains some capacity for weak contractions. If the muscle is completely shot, it won't help much. And it can have side effects mostly related to stimulating gut motility, so things like colic or diarrhea need to be watched for.
Okay. What else?
We might use phenoxybenzamine. This is an alpha-adrenergic blocker. It works to relax the urethral sphincter, the exit valve, making it easier for urine to flow out. It can sometimes be used in combination with ibepicol. Side effects can include constipation or colic.
So one drug to help squeeze, one to help relax the exit.
Potentially, yes, trying to improve coordination. Another drug sometimes tried, though less commonly reported as successful in horses, is phenylpropanolamine. This is an alpha-1 adrenergic agonist. It does the opposite of phenoxybenzamine. It increases urethral muscle tone, so it might be considered for cases thought to be due to urethral sphincter incompetence, a leaky valve. But consistent success isn't well documented. It can cause side effects like hypertension or restlessness.
And you mentioned estrogen for some mares.
Right, for those rare cases of estrogen-responsive incontinence in mares, estrogen treatment can be effective.
So medical management involves antibiotics and potentially these drugs to help bladder function alongside dietary changes.
Yes, dietary modifications are definitely a key component, especially if stones or sediment are involved. For horses with that sabulous urolithiasis, recommending a low-calcium forage diet is standard. That means limiting or avoiding high-calcium feeds like alfalfa or clover hay. We might also consider urinary acidification using agents like ammonium chloride or ammonium sulfate. The idea is to make the urine pH lower, which can discourage some types of crystal formation. However, there's a caution here. Acidifying the urine can sometimes paradoxically increase calcium excretion by the kidneys, which might actually be counterproductive for calcium carbonate stones, so it needs careful consideration.
Tricky balance.
It can be. A simpler approach often recommended is just adding a bit of salt, NaCl, maybe 1 to 2 ounces twice a day to the horse's feed or water. This encourages them to drink more, increasing urine volume and flow, which helps flush out sediment and decrease its concentration.
That makes sense. So medical and dietary strategies. What about surgical options? When do those come into play?
Surgical interventions are usually reserved for specific, correctable anatomical problems or physical obstructions. For urolithiasis, if there are actual formed bladder stones, cystoliths, surgery might be needed. Options include a cystotomy, which is surgically opening the bladder to remove the stones, or, increasingly common, is laser lithotripsy, where a laser passed through an endoscope fragments the stones into smaller pieces that can be flushed out or passed naturally. For stones lodged in the urethra, a procedure called a perineal urethrotomy or ureterostomy might be done to create an alternative opening.
What about for just the sabulous sediment? Surgery?
Generally, no. And this is a crucial point for owners. We try to avoid unnecessary cystotomies just to clean out sabulous sediment. Why? Because in these cases, the underlying problem is usually the large, atonic, poorly functioning bladder. The sediment will almost certainly reaccumulate unless the primary bladder dysfunction is resolved, which is often isn't. Surgery itself carries risks and doesn't fix the root cause.
Got it. So surgery for formed stones, but usually not just for sludge. What about other surgical targets?
For ectopic ureters, surgery is the treatment of choice. The goal is usually ureterovesical anastomosis, which means reimplanting the abnormal ureter into the correct location in the bladder. If only one kidney ureter is affected and it's severely damaged, sometimes ureteronephrectomy, removal of the affected ureter and kidney, is performed. Early surgical intervention for ectopic ureters definitely offers the best chance for continence.
Okay. And either surgical approaches?
For proven urethral sphincter incompetence, surgical repair might be attempted. Other techniques sometimes discussed, like urethral slings, artificial urethral sphincters, injecting bulking agents around the urethra, or procedures like colposuspension. These are primarily described and used in small animals or humans. There's very limited evidence or established success for most of these in horses currently.
It really sounds like in many cases, especially the chronic ones where surgery isn't the answer, that supportive care becomes the absolute main focus, the daily effort.
Absolutely. Supportive care is paramount. It's often the cornerstone of long-term management, especially when curative treatments just aren't feasible or haven't worked.
What does that involve day to day?
A few key things. Regular bladder lavage is often needed. This involves passing a catheter and flushing the bladder repeatedly with sterile saline to physically remove that accumulated sabulous sediment. This isn't a one-time fix. It often needs to be repeated regularly, maybe weekly or monthly, depending on the horse.
Okay, flushing the bladder.
For horses with significant detrusor dysfunction, bladder paralysis, or urinary retention, regular catheterization might be necessary simply to ensure the bladder is completely emptied. This might be multiple times a day in some severe cases.
Oh, that's intensive.
It can be. And then there's the absolutely critical component of meticulous nursing care. Daily hygiene is crucial, gently cleaning the perineal area and hind limbs, keeping the spine dry, and applying barrier creams or emollients like glycerin can help prevent or manage that painful urine scalding. This demands significant ongoing commitment and diligence from the owner.
Nope.
And for horses with specific neurological issues like Cauda equina syndrome that also affects bowel function, we might use fecal softeners or recommend a low-bulk diet to help manage fecal retention alongside the urinary issues.
It really emphasizes that point about the lack of specific equine data for many drugs, meaning vets are often relying heavily on clinical judgment and drawing parallels from other species.
Precisely. And because of that, and because many chronic cases aren't truly curable, this long-term supportive care becomes absolutely fundamental. It's not just an add-on, it's often the main strategy for managing the condition and maintaining the horse's welfare over time.
Given all of this, the chronicity, the challenges, what is the typical outlook for a horse diagnosed with urinary incontinence? And what are the biggest ongoing challenges to their well-being that owners really need to be prepared for?
Yeah, the prognosis, it varies hugely. It really depends on the specific underlying cause, but maybe even more importantly, on the chronicity, how long the condition has been present before diagnosis and treatment. As we mentioned, that overall success rate is sobering. Despite diagnosing the cause in about 80% of cases, only around 20% achieve a truly successful long-term treatment outcome where the incontinence resolves.
So when is the prognosis more favorable?
Generally, a favorable prognosis is associated with problems that are directly correctable through specific treatment. Think surgical correction of an ectopic ureter or successful removal of a cystolith, a bladder stone, before irreversible bladder damage occurs. Also, if the incontinence is due to an acute onset neurological disease, like maybe a mild EHV1 case, and the detrusor and sphincter functions start to return relatively quickly, say within 10 to 14 days, the outlook can be better.
Okay. And when is it typically guarded to poor?
The prognosis is usually guarded to poor for horses that present with chronic detrusor dysfunction. Those cases with a large, overstretched atonic bladder, often filled with significant sabulous urolithiasis. Once that bladder paralysis becomes long-standing, the chances of regaining normal function are generally considered poor.
Are there any specific conditions with noteworthy outcomes?
Well, those rare cases of estrogen-responsive incontinence in mares often respond very well to treatment. And surgical correction of structural abnormalities in mares, like fixing tears from foaling, can also have successful outcomes. That idiopathic bladder paralysis syndrome in geldings, it's challenging to manage, often requiring lifelong care like lavage. But many sources suggest it can often be managed in a way that doesn't necessarily compromise long-term survival, although the quality of life requires careful monitoring and significant owner input.
So even if the primary cause can be identified or maybe even managed to some extent, what are the most common complications that tend to snowball and really impact the horse's quality of life day to day?
The biggest challenge is often that detrimental cycle we keep coming back to. Sabulous urolithiasis, that sludge, is primarily a consequence of the incomplete bladder emptying and the underlying detrusor dysfunction. It's usually not the initial cause itself, but once it's there, that thick sediment further impedes complete emptying, making the problem worse.
Vicious cycle.
Absolutely. And that combination of incomplete emptying and stagnant sediment-filled urine creates a perfect breeding ground for bacteria. So frequent and often significant ascending urinary tract infections, UTIs, are a major complication. These chronic UTIs can, in turn, potentially predispose the horse to forming more solid stones, too.
Okay, sediment and infections. What else?
The urine scalding. That constant or intermittent dribbling causes painful, persistent skin lesions on the perineum or hind legs. Managing this requires tireless, ongoing nursing care from the owner. It's a constant battle. And the chronic detrusor dysfunction itself, the constant overstretching, can eventually lead to complete irreversible bladder paralysis.
In the worst-case scenario,
If bladder stones cause a complete obstruction, or if ascending UTIs are severe and go untreated, they can lead to infection traveling up to the kidneys, pyelonephritis. This can cause severe, potentially life-threatening kidney damage and even kidney failure.
so the core insight here seems to be that the incomplete emptying kicks off this cascade sediment, infections which then further impairs emptying, leading to progressive bladder damage. It becomes this self-perpetuating problem that makes long-standing cases exceptionally difficult to treat successfully.
That's exactly it. The prognosis often reflects the stage of this chronic progression, maybe even more than the initial trigger itself.
So wrapping this up, if it's often this long-term challenge, what can owners and vets actually do to try and prevent it from getting worse, or at least manage it? And most importantly, how do we ensure the best possible quality of life for these horses living with incontinence?
Well, the most crucial message, though perhaps difficult in practice, is early intervention. The response to treatment is consistently reported as being much poorer in long-standing cases. So heightened awareness among owners and vets for those subtle early signs, maybe slight changes in urination habits, mild scalding, is really critical for any chance of therapeutic success.
Easier said than done sometimes, but crucial. And diet, again, plays a role in prevention or management.
Yes, definitely. Dietary management is vital, particularly for those prone to calcium carbonate issues. Reducing dietary calcium by limiting or removing high calcium forages like alfalfa is a key recommendation. And ensuring consistent access to clean, fresh water is simple but important. Encouraging water intake helps keep urine dilute and flowing, reducing the likelihood of stone or sediment formation. It's about maintaining a proper mineral balance overall, tailored to the horse's needs.
But it really sounds like the day-to-day, hands-on care is what truly makes or breaks the management of complications.
It absolutely does. Meticulous nursing care is paramount. It's non-negotiable, really. Urine scalding prevention and management requires daily hygiene, gentle cleaning of the perineum and hind limbs, keeping the skin as dry as possible, and consistently applying barrier creams or emollients like glycerin to protect the skin. This demands a truly dedicated, long-term commitment from the owner.
No doubt.
And as we discussed, intermittent bladder lavage, often on a regular schedule determined by the vet, might be necessary to physically remove that accumulating sabulous sediment. And for horses with significant bladder paralysis or retention, regular catheterization to ensure complete bladder emptying might be required as part of the ongoing management plan.
And finally, addressing any underlying predisposing factors you mentioned earlier.
Exactly. That's part of the holistic approach. Promptly treating any underlying systemic diseases like diabetes or chronic vaginitis can help reduce the risk of secondary urinary complications. We also aim to manage medications carefully, minimizing the use of potentially kidney-damaging drugs like certain NSAIDs, especially long-term. And critically, addressing and managing chronic musculoskeletal pain is so important. If we can keep the horse comfortable enough to posture correctly for urination, treating back pain, arthritis in the hind limbs, etc., we can help prevent that incomplete emptying that kicks off so many problems.
When we connect all this to the bigger picture, it becomes incredibly clear that the owner's dedication, their willingness and ability to provide that meticulous, often intensive nursing care, isn't just a recommendation, is it?
Not at all. It's a fundamental requirement for successfully managing the complications, minimizing discomfort, and ultimately improving or maintaining the horse's quality of life, especially in chronic cases.
Given that often guarded a poor prognosis for complete cure in those long-standing cases, this daily owner commitment directly influences the horse's welfare and the overall effectiveness of any veterinary treatment plan.
It really does. Without that dedicated partnership and daily care from the owner, even the best veterinary strategies will struggle to make a meaningful difference in the long run for many of these horses.
Wow. What an incredible and pretty complex journey we've been on today, really delving into equine urinary incontinence. From understanding that delicate dance of nerves and muscles in healthy urination to the huge range of causes, congenital quirks, infections, trauma, chronic nerve damage, and then all the detailed detective work needed for diagnosis, it's clear this is far from a simple condition. It truly requires a holistic view and, as you just emphasized, an incredible partnership between owners and their veterinary team.
It really does. And this brings up, I think, a critical question for everyone listening to consider. How might increasing our collective awareness, our attentiveness to subtle health changes in all our animals, not just horses, things like early signs of urinary dysfunction, maybe changes in drinking habits, slight stiffness, how could that lead to better long-term outcomes? Not just for incontinence, but perhaps for other insidious conditions that often start quietly but cause significant problems down the road.
That's a great point.
It truly highlights the profound impact of just diligent observation and acting on those early, subtle signs. That early intervention really is key in maintaining animal welfare across the board.
Absolutely. So whether you're a horse owner dealing with this, a veterinary professional navigating these cases, or maybe just someone who loves to learn and explore these complex topics, we really hope this deep dive has given you a fresh perspective, maybe a greater appreciation for the intricacies of equine health, and perhaps some practical insights too. Take a moment to think about what stood out to you most today, and perhaps share this knowledge with others who might benefit. Now, Al, for this deep dive.